Let me first thank very much for inviting me to this conference. Especially my thanks are addressed to the organizers, of course, to Professor Sana Youssef. It is very kind. It is very kind of you. I will talk about different amino acid disorders, mainly mypers Europe, urine disease, methylmalonic aciduria, propionic aciduria, glutaric aciduria type 1, homocystinuria, and urea cycle disorders. I will focus.
I want to stop.
I'm not sure if you can hear me properly. Could you confirm it by chat by some statement or by email? Because I am not sure if I should continue or if everything is okay. Just to know it. Okay, so I will continue. I have no answer from you. What to do? Hopefully you can hear me. Okay, let's start. Let's start from definition of inborn error of metabolism. In a simplified form, it is a disease with a specific enzyme deficiency arising from single or multiple gene defects leading to a block in a metabolic pathway and overt clinical signs and symptoms. These inherited metabolic disorders represent some of the rarest. They are called also rare or even ultra-rare diseases, but most life-threatening unmet medical needs. According to the last international classification of inherited metabolic disorders from January this year, we will be talking now in this presentation about disorders of intermediary metabolism and especially nutrients.
Can you hear us?
I can't see you, but I can hear.
Okay, if you could, doctor, we will just a chairperson will introduce you now. Then, if you can,
I see. Okay, I had a note that I should start my presentation. So of course I can wait. Please do it.
Sorry for that. If you can start from the first slide, and the chairperson will introduce you now.
Okay.
It's a great pleasure to introduce Professor Sykut-Cegielska. She is the head of the Department of Inborn Errors of Metabolism and Pediatrics and Institute of Mothers and the Child, Warsaw, Poland. She is a consultant in pediatric metabolic medicine, and she is the chair of the Polish Society of Inborn Errors of Metabolism. She will present today an interesting topic on general disease overview on different amino acid disorders, maple syrup urine disease, glutaric acidemia 1, methylmalonic acidemia, propionic acidemia, homocystinuria, and UCD. Please, Professor Jolanta, the floor is yours.
Thank you very much for this kind invitation, and thanks for inviting me for this conference. Thanks to organizers and especially Professor Sana Youssef. So I will talk about diagnostic and therapeutic aspects with newborn screening perspective in these diseases that you mentioned so kindly. Let me begin from the simplified definition of inborn error of metabolism. So it is disease with a specific enzyme deficiency arising from single or multiple gene defects, usually single, they are monogenic diseases, leading to a block in a metabolic pathway and overt clinical signs and symptoms. These diseases are also called rare diseases or even ultra-rare diseases because they represent some of the rarest but most life-threatening unmet medical needs. And according to a recent international classification of metabolic disorders, we will be talking about disorders of intermediary metabolism, namely nutrients. And from a pathophysiological perspective, we will touch these disorders, which are also called disorders of metabolic intoxication. Why it is called like intoxication? Because patients really present symptoms of endogenous intoxication. It is intoxication caused by accumulation of endogenous metabolites. It is due to an enzymatic block, so there is a reduce of the product and accumulation of substrate of a specific reaction. So disorders of intermediary metabolism lead to progressive accumulation of toxic products which are proximal to the metabolic block. And among these disorders of metabolic intoxication, we will today talk about inborn errors of metabolism of amino acid catabolism, such as maple syrup urate disease, and also homocystinuria, and some organic acidurias like methylmalonic aciduria, propionic aciduria, and glutaric aciduria type 1. But also at the end about urea cycle disorders. What is important to remember that you can see either acute or chronic intoxication in your child with these above diseases. So what is the general presentation of amino acid disorders? There are groups of clinical pictures in which physicians are faced with the possibility of metabolic disease, such as early symptoms in the antenatal and neonatal period, later onset acute and recurrent attacks of symptoms such as coma, vomiting, ataxia, acidosis, exercise intolerance, or chronic and progressive neurological symptoms like developmental delay, epilepsy, and mental retardation, but also specific and permanent organ or system presentations. So amino acid metabolism disorders are amino acidopathies, which are due to deficiencies of cytosolic enzymes, and they are detected by amino acid analysis in plasma or urine, and classical organic acidurias, which are due to deficiencies of mitochondrial enzymes required for breakdown of coenzyme A activated small carbonic acids, and they are detected by the analysis of urinary organic acids. So these are our diseases. And this slide shows you the metabolic pathway of branch chain amino acids. So there are many enzymatic blocks, so inherited metabolic disorders localized here in this pathway. And we will start from MSUD, which is in the top, as you see on this pathway. So this is disorder of branch chain amino acid like leucine, isoleucine, and valine. And there are various clinical phenotypes. The most frequent one and let's say severe, it is called classical phenotype of MSUD. In this form, acute symptoms in the neonate are usually not highly suggestive. There are no specific clues for this diagnosis, but there is one: smell of maple syrup, which is quite characteristic. And in an intoxicated child, you will always have this impression of smell, a special smell. So how this intoxication syndrome looks like in MSUD patient, there is symptom-free interval, which here is usually more than 3 days or usually in the second week of life. Poor sucking and feeding are typical, recurrent vomiting. So such diagnoses as formula intolerance, pylorostenosis, or congenital adrenal hyperplasia even are suspected. There are, of course, misdiagnoses here. These symptoms lead quickly to dehydration and to reducing of body weight. Abnormal muscle tone, often with the hypertonia and with opisthotonus, but also axial hypotonia and limb hypertonia with large amplitude tremor is usually observed together with myoclonic jerks. Some involuntary movements like slow limb elevation, boxing, or pedaling, these pathologic findings are also observed in intoxication syndrome due to MSUD. Increasing somnolence results in stupor and then in coma, and unfortunately, when not diagnosed at this moment and not treated, patient usually die or presents with irreversible neurological damage. So how to make diagnosis among so-called routine investigations? You can think about MSUD because metabolic acidosis with elevated anion gap is observed and positive urine ketone bodies. How to confirm this diagnosis? By amino acid profile in plasma or CSF or urine, which is highly abnormal with high branched chain amino acids, but diagnostic here and pathognomonic here is isoleucine, which is elevated in intoxication syndrome. Also in dry blood spot, you can find these metabolites, but here leucine goes together with isoleucine, and there is also high value. GCMS profile in serum are usually done in urine, reveals accumulation of branched chain keto acids. So one from leucine, the second from valine, and the third from isoleucine. What is management in MSUD? Restriction of leucine, isoleucine, and valine in the diet to ensure normal psychomotor development through reduction of toxic metabolites, toxic mainly for brain, and leucine is the most neurotoxic. Also, this is important in treatment monitoring. L-isoleucine and L-valine supplementation with regular amino acid profile monitoring is crucial, just to avoid unrequired over-treatment effects, so to avoid the deficiency of isoleucine and or valine. Emergency and long-term treatment, of course, here is recommended. Aim is to stop further intoxication of the baby. How to do it? To stop protein feeds, but not longer than for 48 hours because of avoiding of endogenous protein catabolism, and to stimulate anabolism and reducing in the same way catabolism by giving intravenous infusions of dextrose, which should be started without delay, but also with lipid infusions. This slide shows you values age-dependent and weight-dependent of this dextrose to provide. What is important that if you face hyperglycemia and or glycosuria, do not reduce the glucose infusion. Here, insulin is together with the glucose infusion is recommended. Of course, monitoring all the time glycemia, because insulin also has this anabolic effect. So this is synergistic therapies here, glucose together with insulin. And when the child is really in bad condition and in acute intoxication, extracorporeal toxin removal, hemodialysis or hemodiafiltration is recommended, especially in a neonate or in other patients who are detected by symptoms, so usually symptomatic. Long-term treatment in MSUD consists of a diet with reduction of BCAA based on specific formulas and amino acid mixtures. During catabolic conditions such as infections, fever, or vaccinations also, or prolonged fasting, hypercaloric diet is crucial. And monitoring of plasma amino acids concentrations is also important, not only monitoring of these branch chain amino acids, but also other LAT1 dependent amino acids, because they share the same transporter in brain. Unlike in phenylketonuria, here in MSUD, there is no relaxation in blood levels with increasing age. And there are different target values of leucine, valine, and isoleucine. We use, most centers use these on the slide. And please remember about avoiding secondary isoleucine and valine deficiency by supplementation of these both amino acids. So prognosis in classical form of MSUD is without treatment bad, but with early treatment good, but still you may meet some neurological or psychiatric symptoms, or even brain edema and pancreatitis are reported. There are some chronic complications in the classical form of MSUD, such as arrested brain growth, developmental delay, mental retardation, spastic diplegia, or chronic mental illness. And from newborn screening perspective, for diagnosis, of course, these biomarkers are high leucine and isoleucine and high valine, but for monitoring, you have to separate these both amino acids just to be sure that isoleucine is in a safe level. So for confirmation, plasma quantitative assay of plasma BCAA is needed, and of course, presence of allo-isoleucine makes the final diagnosis. Also, you can do usually in urine profile of organic acids, which shows accumulation of branch chain keto acids. So now let me move to organic acidurias beginning from definition and detection. So accumulation of carboxylic acids is here a mainstay feature. Organic acid profile in urine by GCMS method is diagnostic analysis of choice, but also acylcarnitine profile in dry blood spot by tandem mass spectrometry method is a complementary analysis here. We will talk about two organic acidurias which belong to so-called classical organic acidurias, so methylmalonic aciduria MMA and propionic aciduria PA, and the same slide as before. You can see that these both defects are located in the bottom of this metabolic pathway of branch chain amino acids, so they are close to each other. So that's why we can talk together about methylmalonic as well as propionic acidemia. And phenotype, they share similar phenotype. We differentiate three clinical forms: acute neonatal, which is the most frequent and appears as severe intoxication syndrome, but also acute recurrent with recurrent metabolic decompensations, which are sometimes called metabolic crisis because they are so severe, and with acidosis, pancytopenia, or even stroke-like events, and chronic progressive form with psychomotor development retardation, some psychiatric symptoms, failure to thrive, and hypotonia. There are reported severe long-term complications in both acidurias, like mental development retardation, neurological deficits, or kidney failure, exclusively in MMA here, and cardiomyopathy or long QTC exclusively almost in PA, or recurrent pancreatitis. I would encourage you to look to these proposed guidelines for diagnosis and management in both disorders published in Orphanet Journal of Rare Diseases. There's a table showing frequencies of signs and symptoms in these both diseases, comparing both of them, so you can see that most of these symptoms are similar, but there are some differences. Intoxication syndrome looks like in MMA and PA quite similar as in other disorders, but here asymptomatic interval is shorter. Usually it lasts 3 to 4 days. So when to suspect intoxication syndrome? Important is the critical approach to diagnosis. This is a take-home message, especially for general pediatricians, because this critical approach to diagnosis is crucial to avoid misdiagnosis in this field. So the most frequent misdiagnosis is sepsis, but there are other so-called red flags. Common conditions which may be similar in clinical aspects as inborn error of metabolism, such as intrauterine infection, encephalitis, meningitis, respiratory distress syndrome, perinatal injury, or cerebral palsy than in the course of life. There are many causes of methylmalonic aciduria and increased level of these metabolite in plasma and or urine. Among them, most frequent are non-genetic causes due to mainly B12 deficiency, vitamin B12 deficiency. But also there are genetic causes of methylmalonic aciduria, such as ultra-rare disorders of absorption and transport of cobalamin, and some genetic background, disorders of MMA-CoA conversion, disorders of intracellular utilization of cobalamin, and atypical methylmalonic acidurias associated with encephalomyopathy and usually with massive lactic acidemia with bad prognosis. Cobalamin, so vitamin B12 is a requirement, is lowest of all vitamins in human body, but the metabolism of this vitamin is most complicated. So now I will show you some practical issues. This is the result of organic acid profile by GCMS method, which shows you massive excretion of methyl malonate with increase of methyl citrate, which is important. And looking into different MMA excretion in various diseases, you may see that it is quite significant overlapping of this excretion. So in some cases, you may, it could be very difficult to differentiate the primary cause of methylmalonic aciduria because when it is like 2000 millimole per mole creatinine, you may still think about nutritional background, so deficiency of cobalamin, or mute minus deficiency, or some combined remethylation defects like cobalamin C deficiency. Here, this slide shows you organic acid profile by GCMS method of the patient with propionic acidemia at the moment of diagnosis. So in intoxication syndrome, in intoxication period, there's massive, as you can see, excretion of 3-hydroxypropionate and methyl citrate as well, increased propionyl glycine and T-glyl glycine, but also increased other metabolites together with ketonuria. What is the diagnostic approach in MMA? When MMA and characteristic other organic acids are detected in urine and there is normal plasma homocysteine and no clues, no suspicion of nutritional B12 deficiency, test with this vitamin should be done to look for responsiveness. And of course, enzymatic workup, but it is costly method and time consuming and needs fibroblasts for this assessment. Finishing MMA and PA from newborn screening perspective, it should be said that this population screening is not performed for these two diseases in every country because there are fast positive results possible. So if you need to do a newborn screening for these two diseases, second-tier tests are absolutely required. I mean, measuring total homocysteine, methylmalonic acid, and methyl citrate in the same filter blood spot. So it is crucial. Newborn screening reduces mortality rate in propionic acidemia, but it has not been proved that also influences on a clinical course. So crisis or complications. It is a conclusion from multi-center study network and registry, so-called EIMG, in which we are also a partner. How about chronic management in MMA and PA? It is complicated, consists of diet with limited natural protein, using food of special medical purpose. Important is, of course, to keep proper calorie intake in the compensation period, hypercaloric intake. L-carnitine is used in rather high doses. Biotin should be tried, although usually without any clinical effect because it's cofactor for in propionic acidemia. Metronidazole, also to reduce production of propionate in good bacteria in propionic acidemia. Hydroxycobalamin, so this active form of cobalamin in B12 responsive forms in these forms, specific forms in methylmalonic aciduria. Carglumic acid, which is registered for treatment in MMA and PA, either in chronic management or in emergency regimen. And it is really, when there is marked hyperammonemia, it is really helpful. And of course, regular clinical, biochemical, and dietetic monitoring is important, and emergency regimen if needed. So what does it mean, emergency treatment here? It is extracorporeal detoxification, optimally venous hemodiafiltration, but if not hemofiltration or hemodialysis, peritoneal dialysis is inefficient and slow. This method is especially recommended in late diagnosed patients with organic acidurias, and it should be started urgently when ammonia exceeds 500 micromole per liter. Together with this emergency treatment, reducing catabolism by high energy intake of glucose up to 10 to 12 milligram per kilo per minute. So to obtain at least 120 or more, even calorie per kilo per day, calculating together calories from oral intake if possible, together with intravenous. And to use insulin, as I have just told, and fat emulsions are here helpful, of course, after exclusion of fatty acid oxidation disorders. The outcome of MMA, PA, and also isovaleric aciduria in the neonatal period is highly dependent on the speed with which the diagnosis is suspected and treatment started. So another take-home message is, do not, for all of us, do not miss the treatable disorder. So let me now talk about glutaric aciduria type 1, which is in fact a cerebral organic aciduria. It is due to deficiency of glutaryl-CoA dehydrogenase. So the enzymatic block results in accumulation of glutaryl-CoA, and there are three, in fact, precursors for this metabolite. I mean, lysine, hydroxylysine, and tryptophan. This is typical organic acids profile in the patient with glutaric aciduria type 1. You can see massive, again, glutaric acid together with increased 3-hydroxyglutaric acid. So characteristic profile for GA1. Pathomechanism is quite complicated. What is known that striatal injury is here a main feature. It is developed in untreated patients during catabolic conditions or in insidious clinical course, but during the so-called vulnerable period, which is here 3 to 36 months of age. Also, some precipitation of excitotoxicity and oxidative stress plays a role, and there is impaired cerebral energy metabolism via inhibition of a Krebs cycle and decarboxylic acid shuttle between astrocytes and neurons. And there is quite known popular so-called trapping hypothesis here in the pathomechanism in GA1, because the blood-brain barrier plays a role in trapping intracerebrally produced neurotoxic decarboxylates due to low BBB permeability. And evidence for this hypothesis was that detection that cerebral concentrations of these metabolites GA and 3-hydroxyglutaric acid are 100 even to 1,000 fold higher than those in plasma. Strikingly, patients with complete enzyme loss, they are called high excretors, have similar concentration as those with residual activity, they are called low excretors. But it is concluded that they may share the same risk of brain injury. What is now about clinical course? Macrocephaly may be detected prenatally, and it is usually seen in the patients, but not in all of them. And acute encephalopathy, which occurs usually between half a year and 1.5 years in the small patient during even mild infection or vaccination. This clinical deterioration with vomiting, apathy, neurological signs like here specifically dystonia and spasticity is very typical in glutaric aciduria type 1. And what we should be aware that all these symptoms are irreversible. But there is another clinical phenotype, is neurodegenerative chronic course with dystonic spasm and seizures, and recently reported late onset form of glutaric aciduria type 1 with dementia, tremor, and epilepsy. Here again, I would encourage you to look to this diagnostic and therapeutic recommendation. This is already second revision for this disease. What are treatment principles in GA1? The first, but all they go together, is L-carnitine in very high doses. Minimum is 100 milligram per kilo per day. And diet with lysine and tryptophan limitation, usually with lysine-free and tryptophan limited amount content. But it is important to initiate this diet very early. But on the other hand, this diet usually could be relaxed after 6 years of age. So it is important not only for dietitians. Crisis management, of course, important because prognosis depends on time of diagnosis, so time of treatment start, and appropriate intervention in crisis. So when emergency regimen in glutaric aciduria type 1 is needed, when there is infection with poor appetite and or fever and vomiting or diarrhea, and vaccination because usually connected with poor feeding, surgery because usually requiring longer fasting. What to do? To drink frequently as an exogenous energy source like glucose polymers, to maintain intake of these special formulas if of course possible, if tolerated. To maintain L-carnitine supplementation here in emergency, we usually recommend to double dose which was used, and to use symptomatic treatment as recommended by the pediatrician. But if the child's condition is not improved satisfactorily, urgent admission to hospital is necessary in order to give intravenous glucose and monitor the status of the child. Here, these preventive hospitalizations are of a really great importance. And this slide shows you two Kaplan-Meier's curves, as you see, with the comparison of patients, outcome of patients detected by selective screening, and these identified by newborn screening in the letter in red line. So you can see, I hope, in this slide that usually patients detected by newborn screening have no or very rarely present with encephalopathic crisis, and all of them survived, whereas only half of them detected by symptoms survived to adult age. This is a combined effect of newborn screening, but also of lysine restriction and carnitine supplementation, and of course a result of intensified emergency treatment. So again, it was concluded and reported in a Journal of Inherited Metabolic Disease as a result of multi-center study that newborn screening is the most beneficial intervention to prevent irreversible cerebral damage in patients with methylmalonic aciduria cobalamin minus and glutaric aciduria type 1. Now I would like to share with you some practical issues and from newborn screening perspective in terms of glutaric aciduria type 1. So here a C5DC is a biomarker but can be normal, especially in these low excretors. When there is high C5DC but low free carnitine and no mutation is found, suspicion of maternal GA1 should be arised. Asymptomatic patients with abnormal newborn screening results during the diagnostic period still should be provided with sufficient, I mean here, high calorie intake. And this dietary treatment without delay is absolutely necessary. A proportion of free lysine formula and human or infant milk depends on current lysine and tryptophan plasma levels, so they should have to be monitored regularly, and both too high or too low lysine and tryptophan levels are unrequired in terms of neurological condition. So now let me move to another disease. It is hyperhomocysteinemia. It is the deficiency of CBS, in this methionine homocysteine cycle. So we will talk about the so-called classical homocystinuria, which is due to cysteine beta synthase CBS deficiency. A clinical picture is quite heterogeneous. Eye is the organ affected always with myopia, with sub or luxation of lenses, ectopia lentis, or other disorders like symptoms like glaucoma or cataracts. Skin and hair is affected as well. There is decrease in pigment, fair skin and hair, pronounced malar flush, and blotchy erythema and pallor and livido reticularis, particularly common in the distal extremities, which may be quite cold and show other evidence of vascular instability. There are a list of skeletal abnormalities in homocystinuria, such as genovalgum, feet may be averted, marfanoid appearance, and arachnodactyly, though true arachnodactyly is here rare. And general osteoporosis. Half of the patients have osteoporosis early in life, by the end of the second life decade, but pectus carinatum or scoliosis and fish-like spinal bones may be also observed. And last but not least, here, a vascular disease. It is a major cause of morbidity and the most frequent cause of death in homocystinuria. This thromboembolism may affect arteries or veins as well, and even myocardial infarction may be seen. There are also some neurological symptoms in classical homocystinuria. Mental retardation is quite common, with mean IQ around 65, and dementia in most of the patients, but also seizures in 20% of patients, and some in half of them, some psychiatric abnormalities like depression or bipolar disease or disturbed personality. Especially in adult patients, these psychiatric symptoms are usually observed. So how to make differential diagnosis when homocysteine is elevated? You have to measure also methionine and probably cysteine. And if methionine is elevated and cysteine is low, CBS deficiency is suspected, and then vitamin B6 test should be done to detect these B6 non-responsive or B6 responsive patients. It's half of the patients are B6 responsive and half of them not responsive. So the goal is to normalize plasma homocysteine as low as possible. And how to do it: to boost residual enzyme activity, to reduce load on the metabolic pathway affected, to supplement with the deficient product downstream of the enzyme defect, like cysteine supplementation, and use an alternative pathway to eliminate the toxic substrate. I'm I find it in my emails that I'm asked to stop after UCD. That was my plan, so I will do it in a moment, if I may. I hope. So dietary management elements in homocystinuria is the first is vitamin B6 if pyridoxine responsive form, second betaine to lower homocysteine, third diet with low amounts of methionine, and if possible also cysteine supplementation. This is helpful. There is a lack of consensus regarding recommended.
Kindly, Professor Jolanta.
Yes.
We are short of time.
I see. Okay, so I should stop now, or you would like to continue from?
If a couple of minutes, it's okay.
Couple of minutes. Okay, so maybe I will talk about homocysteine and then finish. It's okay?
Okay.
Okay, thanks. So because it's really interesting, and I think important that this target value is usually below 50 micromole per liter, but some centers say that even 100 is achievable here in these patients. So from newborn screening perspective, biomarkers of homocystinuria are methionine and ratio methionine-phenylalanine, but they may be unreliable, so the second tier tests are important, and to confirm the diagnosis, to establish final diagnosis, CBS enzyme activity, which may be done in blood now, in PRAC or DNA analysis, is helpful. These are recent recommendations versus current practice. So if you think you want, I will finish here. Only urea cycle disorders are left now. So, but what can I say? Essential for the diagnosis is think of hyperammonemia, measure ammonia, remembering about different clinical presentations in newborns, intoxication syndrome, in infants, toddlers, usually less dramatic, but without treatment, also progressive course. In adolescents, mostly psychiatric and neurologic. This is the very helpful differential diagnosis made by Haberle published in Journal of Mother and Child in our journal. So treatment options, emergency and outcome, and from newborn screening perspective, some of these diseases can be diagnosed, but it is quite difficult to diagnose urea cycle disorders from newborn screening, so from dry blood spots. So if I have to finish, I am finishing now. Thank you very much for inviting me, for your attention, and if you have any questions or comments, I will be happy to take them.